Deveshwala.
Good morning, everyone. Can you all hear me? Okay, all right. So today I'm going to be talking about a case report that we ended up correcting a large left superior vena cava to a left atrium fistula percutaneously. We have no disclosures. So this is an extremely rare congenital heart condition, and in the Mayo Clinic review showed that only 0.5% of the patients have a anomalous drainage of the left SVC into the left atrium. So just to give a revision of the anatomy, we have the superior vena cava and the inferior vena cava draining into the right atrium, going into the right ventricle, into our lungs, and then back into the left atrium, left ventricle, and to the whole body. And what we see in an anomalous left superior vena cava is that we have this other vessel called the left SVC. So most of the times it drains into the right atrium, and sometimes it can, via the coronary sinus or without any connection with the coronary sinus, drain into the left atrium, and that can cause a right to left shunt. And how does this happen? Well, and if you remember embryology from med school days, you have your anterior and posterior cardinal veins that form the common cardinal vein and drain into the sinus venosus, which is the fetal heart. And the right side, the anterior cardinal vein and the common cardinal vein form the SVC, but on the left side, it usually regresses. And if the regression does not occur, then there is a persistent left-sided vascular structure called the persistent left SVC. So our case is a 63-year-old woman. She presented with shortness of breath and exertional hypoxia. And she had a history of cognitive decline and multiple CVAs in the past. A transthoracic echocardiogram showed a positive bubble study, which means that the bubbles were seen in the left atrium before they were even seen in the right atrium, suggestive of a shunt. And remarkably, the right ventricle and the left ventricle were not hypertrophied, which you would expect if you had a huge shunt. We did end up doing a CTA that showed the left SVC entering the left atrium. And we also saw a bridging vein between the left SVC and the anatomical, the right SVC. And we ended up getting a CMR that showed the fistula's connection. So so the next part of my presentation is more of the procedural aspect of it, so feel free to interrupt me if you have any questions about the fluoroscopy views and things like that. So we took her to the cath lab, and the reason that we did that was that the patient was an old, frail patient, and we did not think that she would be a good surgical candidate for the correction of this fistula. So we took her to the cath lab, we got left IJ access, and then we also did a right heart catheterization, which showed normal filling pressures and cardiac output. And so so this is our pigtail catheter advancing into the left SVC, and as you can see, the contrast going in from the left SVC into the left atrium. And then you can also see a bridging vein here. And so we were able to exchange the pigtail catheter with a super stiff wire and pass it from the left atrium into the right upper pulmonary vein. And we used a compliant balloon to see the size of the defect. So the defect was not circular, so we could not use an Amplatz, the septal occluder that we usually use. So that's why we ended up using a covered stent to fill the defect. And so we again exchanged our wire. This time around, we used the wire to go into the coronary sinus, into the right atrium, and into the IVC over here. And then we were able to cover the defect with a covered stent. And completion angiography showed that the defect was mostly covered. However, there was a small opening at the distal end, and we thought initially that it was inconsequential. However, the patient returned within a month, 2 times with exertional shortness of breath, and that's why we decided to do another procedure to close that residual defect that she had. So again, we got left IJ access, and again, angiography showed that there is some contrast that goes from the left SVC into the left atrium. And we wanted to make sure that we have enough coronary venous drainage. So we were, from the right IJ, we were able to use a diagnostic catheter to cannulate one of the coronary veins right below our stent. But we weren't able to get any other veins through this approach. So we went into the left SVC, and we were able to see the middle cardiac vein. And fortunately, the middle cardiac vein had collaterals to the lateral collateral vein. So we, even if we placed a stent very close to that vein and we were to occlude that vein, we would have enough venous drainage. So we went ahead and we placed another stent, and then conclusion angiography showed that there was no defect after the procedure. So in most cases of the persistent left SVC, like I said before, it drains from the coronary sinus into the right atrium, so those patients are usually asymptomatic. But if you have the persistent left SVC draining into the left atrium, it causes that shunt and causes patients to be symptomatic. Some of the patients have paradoxical embolism, and our patient had multiple CVAs, so we really think that that was her cause of the CVAs. And in some case reports, it has been noted to even cause brain abscesses. It can cause cyanosis and heart failure if the defect is huge. And it was really unusual that our patient did not have any hypertrophy or anything like that, but it is just an unusual finding in our case. And so because of this, rare condition, we need to be aware of this, and we ended up doing a percutaneous closure because of the poor, because she was a poor surgical candidate. And just a follow-up to this case, she's actually doing very well, and her symptoms have resolved. Thank you so much, and any questions?
Good presentation, Nakia. I have one question. So this patient, you'd mentioned it wasn't a good candidate for surgical and it was better for percutaneous. What was some of the reasons for being a poor candidate for a surgical approach?
So mostly frailty was one of the reasons. The cardiothoracic surgeons evaluated her for CT surgery and did not think that she would, be a good surgical candidate.
Okay.
Yeah.
Thank you.
Thank you.
Do you want to introduce them?
So is this your name?
Oh, it's going this way. Okay,
Yeah.
never mind. The other gentleman was next.
Okay. Nakia? Okay, so the next one, let me see, Dr. Odak? Okay.
All right. Next, we'll have Dr. Mihir Odak giving us a presentation on the use of Impella CP in the treatment of peripartum cardiomyopathy complicated by cardiogenic shock.
Thank you very much. Good morning, everyone. My name is Dr. Mihir Odak. I'm a third-year resident at Jersey Shore Medical Center in Neptune, New Jersey. I hope you guys can hear me okay. Today I'm going to be talking about a case of the use of Impella CP in the treatment of peripartum cardiomyopathy that was complicated by cardiogenic shock. So today we're going to be talking about the use of mechanical circulatory support, particularly in cardiogenic shock that arises from peripartum cardiomyopathy. It's a case that we understand to be rare. but certainly has a significant morbidity and mortality associated with it. And because of that, it's garnered significant interest in the cardiovascular community recently. Impella is one such device that's been used. It's been studied previously, but we really don't know how effective it can be. And so the purpose of this presentation is to highlight a case where it was used effectively in the treatment of cardiogenic shock. This is my disclosure slide. I have none to disclose. So we recently took care of a 31-year-old female, G2P1001, who had a history of hyperlipidemia, who came to us at 32 weeks gestation for nausea. When she presented to us, her blood pressure was 152/108, and she was otherwise asymptomatic, was not complaining of any chest pain or shortness of breath at the time. And of note, her antepartum obstetric period was not evident for any LV dysfunction whatsoever. So she was diagnosed with preeclampsia with severe features. She was given magnesium and labetalol for her blood pressure and preeclampsia, and she was planned for a cesarean section. I'll come back to this slide for the remaining 2 bullet points, but she had an additional history of gestational hypertension during her prior pregnancy, history of type 1 diabetes as well, for which she was on insulin 30 units twice a day. She was on atorvastatin 40 milligrams for her hyperlipidemia, and for her prior pregnancy, that culminated in a C-section due to fetal macrosomia. She did not smoke cigarettes. She only used alcohol, but prior to pregnancy, no alcohol use was during pregnancy, no illicit substance use as well. She worked as an administrative assistant in an office. However, she did have quite a sedentary lifestyle. And she had no prior family history of cardiac disease or sudden cardiac death. So her vitals, as I mentioned, when she presented, her blood pressure was 151/101. Her heart rate was 115. She was saturating 96% on 2 liters via nasal cannula, and she was afebrile. And her physical exam was grossly benign. She had no cardiovascular signs on exam that were abnormal, no pulmonary exams as well. Her effort was normal. Her extremities were warm. She was well perfusing as well. So she ultimately proceeded to have a cesarean section. So during the closure of the abdominal fascia during the procedure, she developed respiratory distress, followed by ventricular fibrillation arrest. So CPR was performed for about 30 minutes. She was defibrillated 3 times. Amiodarone was administered as well, and ROSC was achieved thereafter. So this is her EKG. This EKG was performed a little bit prematurely, but it was immediately post-arrest or post-resuscitation. So as you can see, there's some anterolateral ST depressions, which kind of led us down the path of ischemia as the cause of her arrest, which was followed by a echocardiogram. So as we have the parasternal long and short axis views here, so as you can see, there's a significantly depressed visually estimated LVEF, about 15 to 20% is what we can probably infer from this echocardiogram. This is the same echo, but from an apical 4-chamber view, and we also have M mode on the side. So like I said, pretty severely depressed LV ejection fraction. She was immediately taken to the cath lab. We wanted to see if there's any acute coronary syndrome going on. So on the far left, we have a shot of the left system. There's no gross flow-limiting lesions there. On the right, we have the right corner. In the middle, we have the RCA shot. Again, no flow-limiting lesions there. And this was followed by Impella placement, which we have on the far right, and that's the Impella pump that was placed right afterwards. So as I said, there was non-obstructive coronary arteries on the left heart catheterization. There was no spontaneous coronary artery dissection as well, and the LV-EDP was 20 millimeters of mercury. The right heart cath, on the other hand, showed a PA mean pressure of 25 millimeters mercury. She had a wedge pressure of 20, a FIC cardiac output of 3.3 liters per minute with an index of 1.7, and a peripheral vascular resistance, a pulmonary vascular resistance of 121 Woods units. And her LV-OT EVTI was 10 centimeters, which, as we know from Tan et al. And a study done in 2017, is a prognostic indicator of very high mortality and can indicate very severe cardiac systolic function. So to summarize what's going on, so we had this patient who came in with cardiac arrest that started after she had fascial closure during a cesarean section. Her post-arrest course was complicated by cardiogenic shock. Unclear at this point what the exact cause of it was, so we took her to the cath lab to make sure there was no ischemia. There was not any ischemia, but because of deteriorating MAPS, despite being on dobutamine and vasopressin, she was not really responding to inotropic support, so that's why we upgraded her to mechanical circulatory support in the form of Impella. She was also considered by cardiothoracic surgery in case VA ECMO was an option for her. Ultimately, she did not need it. But over the next 2 days, her lactic acid declined from 7.3 to 1.2, and her cardiac output was increased to 9.8 liters per minute with a cardiac power output of 2.3 on P3 Impella settings. She was ultimately weaned off of pressors. Impella was explanted the same day, and she had excellent hemodynamic results. She was then extubated the day after. She was transferred to the telemetry floor the day after that, and she was discharged to her home with her baby 2 days later. So this case was kind of a conundrum for us, exactly what happened, why things progressed so rapidly. Her picture wasn't really consistent with an amniotic fluid embolism. Pulmonary embolism was also on the table as a differential diagnosis. As for her left heart cath, there was no signs of SCAD or acute coronary syndromes. So really we were thinking this is potentially just a peripartum cardiomyopathy that had a very rapid onset versus an infiltrative process. Less likely an infiltrative process considering the acuity, but considering that inotropic support failed to adequately support her hemodynamics, that led us to the decision to use mechanical circulatory support to offload the left ventricle. So this is her echo at her 3-month follow-up appointment, which we see pretty good response of her left ventricle afterwards. Visually estimated as about 40 to 45%, but she was able to return to her baseline. She's taking care of her baby now, and she's on her path to recovery. So there's been recent evidence published in the American Heart Association that show the progression of the left ventricle ejection fraction up to 29% using mechanical circulatory support as a temporary, or rather a temporizing measure. There have been different forms of mechanical circulatory support used. Overwhelmingly, this has been in the form of ventricular assist devices, followed by intra-aortic balloon pump, and then Impella. Our case demonstrates and corroborates the use of Impella as a means of mechanical support in these patients as an option for peripartum cardiomyopathy complicated by cardiogenic shock. Which begs the question, could potentially gestational hypertension be playing a role here? Which is potentially a form of expanded study, but could this patient's prior history of gestational hypertension have contributed to her ongoing left ventricle issues? And should we be screening these patients for LV dysfunction if we diagnose gestational hypertension, either in the same pregnancy or prior pregnancy? So again, we demonstrated the successful use of Impella CP in cardiogenic shock resulting from peripartum cardiomyopathy. The role of mechanical circulatory support kind of enabled the team to rapidly wean down her pressors. We were able to offload the pressure in the left ventricle and ultimately led to a shorter stay in the CCU in the hospital altogether as well. While there has been implementation of mechanical circulatory support for this syndrome, there's literature on it now, but perhaps we need larger trials focusing specifically on Impella. But considering the morbidity and mortality of this condition, those trials may be marred by how risky this condition is and patient safety. So with that said, these are my references, and thank you very much for your time.
So, very nice case, very intriguing. Congratulations to the team taking care of this patient. So this patient was discharged without neurological deficits to home.
Correct.
Okay. So, was a CTPA done to rule out PE during hospitalization?
It was done. It was negative for PE.
Okay. So, very interesting case. The thing that kind of doesn't add up is 30-minute, ROSC with no neurological deficit, almost like a little miracle. But if it is not a miracle, it begs a question, was it a true cardiac arrest. There was VT, there was arrhythmia reported. Could she be going in from VFib to VT, and kind of having some kind of perfusion leading to non-neurological deficit, which is a miracle if it was a true cardiac arrest. And this EF that we found, very low EF, could it be the kind of post-arrest and the cause, or could this be, I'm just guessing, like some Takotsubo induced by, stress from, her pregnancy complications leading to the low EF, putting her at risk of actually going into, VT arrhythmias or VFib, and then kind of leading to this kind of arrest. I'm saying that because of non-neurological deficits after 30 minutes. So a very intriguing case, but you could raise, with clean coronaries, with low EF that is transitory in a way, it sounds like Takotsubo to me. I'm just guessing because I don't see the clear diagnosis in the end.
Sure. So yeah, those are excellent points. I agree. Takotsubo is definitely a consideration. She just had gone through a surgical procedure. If it were to be Takotsubo, I would think that it would be an atypical presentation. On the echocardiogram, there was no typical features of the Takotsubo morphology, but certainly a possibility. Another thing is that this arrest happened in the obstetric unit. I personally wasn't running the code, but it's also possible that we had intermittent ROSC, which would support the findings of no neurological deficits. But as you said, with 30 minutes of downtime in the worst case scenario, it is a miracle that she had no neurological deficits. So.
No, very good case. Cardio-obstetrics is, it's a hot topic right now, and there's very limited data on how we manage these patients. I don't really have much. It was a good case, good presentation.
Thank you very much. Thank you.
Anyone else has any questions? No.
So we chose dobutamine for its inotropic contributions. We wanted to, every pressor for the most part increases demand on the heart. And prior to taking the patient to the cath lab, these pressors were initiated. She had an initial hemodynamic response to the dobutamine, and a bedside echo that was done showed that she had extremely compromised cardiac output. With the VTI of 10, we wanted to try the best inotropic support that we possibly could, and we felt that dobutamine has a better contribution to that than norepinephrine, levofed, or norepinephrine. And of course, we wanted to avoid milrinone because of her hypotension.
Yeah. No, that's a very good question, and we can understand the selection of pressors and managing this case because this truly is a hot topic, and unfortunately, we don't have enough literature to back up every single step of the way with our decision making. So, you cannot argue with success. The story was a successful one. But as I say, these things still happen, and unfortunately, many doctors don't have just enough literature to back up for every single, clinical decision making as they make in a lady that is young, type 1 diabetic, having a cardiac arrest at 32 weeks of pregnancy. How many studies you have out there that actually studied outcomes in type 1 diabetic cardiac arrest pregnant ladies? So you cannot argue with success. You kind of go through your kind of theoretical knowledge and you hope it matches the practical outcome. But your point is well taken. But as I say, you cannot argue with success.
Any other questions? Okay.
Thank you.
Thank you. Is it your or no? It's okay. Okay. So this was ODAC 231. Okay. Dr. Sluzarenko. Okay.
Can you all hear me? All right, good morning. I'm Dr. Scott Slusarenko. I'm a third-year internal medicine resident at Legacy Emmanuel in Portland, Oregon. I'm here to present a case called transient right-to-left intraatrial shunt leading to critical hypoxia and dialysis intolerance. I have no disclosures. So our case begins with an 83-year-old female admitted for acute on chronic hypoxic respiratory failure. Her symptoms occurred during dialysis. She would start her dialysis treatment course, become hypoxic, dyspneic, and her treatment regimen would have to be stopped early. She was admitted to the hospital and required NIPPV for her pulmonary mechanics, as well as recurrent episodes of stopping her dialysis treatment. This is a recurrent episode that was replicated multiple times during her admission. She was intolerant of her hemodialysis prescription, which in the long term would have been life-limiting. When not in extremis, she had a negative review of symptoms. She had a history of pulmonary sarcoidosis stage 2, moderate persistent asthma, chronic hypoxic respiratory failure, sleep apnea, end-stage renal disease, ischemic stroke, and atrial fibrillation. When she was not symptomatic, she had stable vital signs and she was on her baseline 4 liters of oxygen. Her lab values are shown, which are not contributory to this case. Her most recent set of pulmonary function tests included an FEV1 of 65% predicted, an FVC of 1.56 liters or 77% predicted, total lung capacity 57% predicted, diffusion capacity 50% predicted, and no bronchodilator response. During her admission, we did a CT angiogram to evaluate for her cause of hypoxia. No PE was noted. She did have consistent reticular changes, nodularity, bronchiectasis, and some honeycombing consistent with her prior films. So to investigate her condition, we looked at the differential for hypoxia. So the differential includes alveolar hypoventilation, ventilation perfusion mismatch, diffusion limitation, dead space, low FiO2, low barometric pressure, and shunt physiology. We worked our way through our differential, and we were left with one option, shunt physiology. Now, I had said that she had a history of an ischemic stroke in the past. During her previous workup, a patent foraminovalia was noted. This is a sample from a TEE, or transesophageal echo, showing a patent foraminovalia at 3.2 millimeters with bidirectional shunting. Her EF was preserved in the study at 60%, and her RBSP was about 25. So a patent foraminovalia is a congenital abnormality where there is lack of contact and closure between the septum primum and the septum secundum. The incidence is about 27% of the population, or about 1 in 4 individuals walk around with this phenomena. There is an equal distribution between males and females, and the distance ranges from about 1 to 19 millimeters. A majority of patent foraminovalia, or PFOs, do not require any intervention along one's normal lifespan. Some potential indications for PFO closure, though, are going to be individuals with cryptogenic stroke, decompression sickness, platypnea orthodeoxia syndrome, migraine with aura, or enhancing features such as larger size, greater than 2 millimeters, atrial septal aneurysm, or other morphologies of concern. So our patient had previously been evaluated for an ischemic CVA and was not offered a PFO closure, even though that was present. Based on this framework published in 2018, our patient at that time was not a candidate due to age, likely cardioembolic source, history of atrial fibrillation, history of end-stage renal disease, so medical therapy was offered at that time. So back to our case. So we still had not ameliorated or really been successful in treating our patient's symptoms, and her symptoms occurred during dialysis. So what we did is we did a TTE while she was symptomatic on dialysis. Her symptoms and her positional intolerance highly limited our ability to get further images, but we did do a bubble study that did note right to left shunting. It's kind of hard to see in this view, but if you look, you do see appropriate shunt as identified on this study. So, going forward, we had to see what we could do for our patient. So a multidisciplinary team got together, and we discussed placing a PFO closure device for her. She was ultimately offered the procedure, consented, and it was placed without difficulty. The theory here is that during hemodialysis, Our patient had increased right atrial pressure, which increased her right to left shunt, causing hypoxia. Her symptoms would wane pretty quickly after being taken off the circuit, and then they were reproducible multiple times during the admission. So after placement of the device, a TTE showed good approximation and resolution of the bidirectional shunting. In conclusion, our patient regained full tolerance for dialysis. As I mentioned previously, this would have been a life-limiting restriction for her given her intolerance for her prescription. She was not a candidate for peritoneal dialysis. She was happily discharged within 48 hours. Upon follow-up, she actually had a reduction in her home oxygen use. She was previously on 4 liters, 24 hours per day, but was now reduced to 2 liters overnight and on room air with activity during the day. In summary, providers and patients should engage in a shared decision-making model when a potential benefit for PFO closure is identified. In certain cases, significant benefits may be derived. Here are my references. Thank you very much.
Great presentation. Does anyone have any questions? Okay.
So yeah, definitely a hot topic, especially PFO closure. So basically, in your case, it was hypoxia and other, symptoms that led it to the closure. We see that it's more restrictive and getting more restrictive in the adult population to actually qualify for, PFO closure. But kudos to the cardiology team to actually do a TEE during dialysis. That was really good investigation work.
Yeah, we did a TTE during that. Definitely, yeah.
So, yeah,
Yep.
amazing.
Yep. All right.
Okay, thank you very much.
Thank you.
Next, we have a presentation by Dr. Udongwo on the red white sign on cardiac MRI, left dominant arrhythmogenic cardiomyopathy, and atypical etiology of sudden cardiac arrest.
Thank you. Good morning, everybody. My name is Ndawsing Udongwo. I'm one of the PGY3 residents at Jersey Shore University Medical Center. So today I have an interesting topic, and also it's a little bit controversial as well. So I'll just dive right in. The learning objective is, number one, to talk about arrhythmogenic cardiomyopathy, and specific to left dominant arrhythmogenic cardiomyopathy. Talk about the diagnostic criteria that are already available, and also talk about the management strategies. So our history is a 44-year-old male, had a past medical history of type 2 diabetes, hypertension, hyperlipidemia, obesity class 1, and he was also a chronic smoker. He came to the hospital after an out-of-hospital cardiac arrest, which he achieved ROCs after 14 minutes. Also got defibrillated twice. When he got to the hospital, he already was he was conscious, so he was able to give brief history. He denied any recent illness, any travel history, any recent stresses at work. So for his medical history, he was on metformin, 1,000 milligrams BID. He was on amlodipine, 5 milligrams, and lisinopril as well. And for his hyperlipidemia, he was on atorvastatin, 20 milligrams daily. No surgical history, had no family history of heart disease or sudden cardiac death. And he lived a sedentary lifestyle, smoked about 2 packs of tobacco daily for about 12 years. Was also a construction worker. Did not use any he didn't use any illicit drugs, or did not vape. For his initial presentation, his vitals, he His blood pressure was 140/87. It was slightly tachycardic. Had a respiratory rate of 18. Was on room air. Temperature was normal, and he had class 1 obesity. For his physical exams, mildly distressed, tachycardic, did complain about chest tenderness, and we're supposing it was after the cardiac arrest he had out of hospital. And for his initial lab work, his troponin was 0.05, but peaked at 1.14. CBC was normal, potassium was about 3.3, BICAP was 21, BNP was 268, and his urine drug screen was unremarkable. Okay, so for his initial workup, he had an EKG that did show borderline LVH, and also had borderline left atrial dilatation from the P waves that we noticed. And his X-ray did show bilateral infiltrate was mild. And we did a CTA because we also wanted to rule out PE, other causes that that might have led to the cardiac arrest. But PE there was no PE. We noticed a little slight LVH from the CT scan. And his initial 2D echo showed an EF of 30 to 35%. Was moderate increased LV cavity, and LVH was also noticed with global hypokinesis. There was no valvular disease. And just to go through the workup, just to make sure that he didn't have any coronary artery disease, we did a coronary angiography. Most of the results not mentioned here, but he had no diseased vessels. There was no SCAD. His LVDP, I remember, was about 18 millimeters mercury, just slightly elevated. So because after the coronary angiography, everything, it was all negative, he had a non-ischemic cardiomyopathy. So we wanted to go further, or we wanted to do a cardiac MRI. And cardiac MRI, the result he showed right here on the B part, ring-like configurations with left ganglioma enhancement, mostly in the inferior lateral wall in the left ventricle. Same thing you can see in A, C, and D as well. So we had all the differentials. So we wanted to do all the workups. We wanted to rule out amyloidosis, hemochromatosis, sarcoidosis. So most of our workup came back negative, even for myocarditis. It didn't, the specific finding we had on cardiac MRI, which was specific to inferior lateral wall, the left ganglioma enhancement, was something that actually ruled out things like sarcoidosis and myocarditis. So our thought process was this probably was left dominant arrhythmogenic cardiomyopathy. So because his EF was low, we started on carvedilol, 6.25 milligrams BID, and because we knew he just came in out of hospital cardiac arrest and had non-ischemic cardiomyopathy, he had an ICD was placed. Unfortunately, he was lost to follow-up, so we didn't go further with the genetic testing, and hence our discussion. The reason why we thought this patient had left predominant cardiomyopathy was based on the CMI, the cardiac magnetic resonance imaging findings. So arrhythmogenic cardiomyopathy itself is fibrofatty replacement or infiltrate forming scar tissue that could lead to fatal arrhythmias. And the classification actually started with the ITF, which is the International Task Force, that started in 1994, and then they modified the criteria in 2010. But unfortunately, they were not able to explain LDAC, which is the left dominant arrhythmogenic cardiomyopathy. They only were specific to the arrhythmogenic right ventricular cardiomyopathy. But we have three variants. There's arrhythmogenic right ventricular cardiomyopathy, there's the biventricular cardiomyopathy, and then there's the left predominant arrhythmogenic cardiomyopathy. But International Task Force failed to explain the third one, which is the left dominant, which is what we're suspecting in our patient. But recently, 2 years ago, a group of scientists came together in Italy. It's now called the Podal's criteria. So there's a new criteria called the Podal's criteria, and basically it now involved the left dominant arrhythmogenic cardiomyopathy. But the caveat is currently there is actually no gold standard test in diagnosing this cardiomyopathy. So some of the learning points, unfortunately, because our patient with the international, the PODAS criteria, one of the things that suggested was if you have major criteria, meaning you had the fibrofatty infiltration in the inferior lateral wall, plus if you had a genetic mutation, because we noticed most of these patients actually had desmosomal or non-desmosomal mutations, meaning like you had desmoplakin, desmoglin, most of these patients, plus the major criteria, which is the left gadolinium enhancement in the inferior lateral wall, did suggest that you had left abdominal rheumatogenic cardiomyopathy. But unfortunately, like I said, our patients did not get the genetic mutation, but still had the CMRI finding. And the reason why we also thought about it was there was a study that was done by Dr. Felix in Spain, that he, in the study, basically they noticed about 93% of patients that had this subepicardial fibrofatty infiltrations with left gadolinium enhancement. In this patient, actually did have left abdominal arrhythmogenic cardiomyopathy that was specific to the left ventricular wall. So some of the learning points, LDAC is a rare variant of arrhythmogenic cardiomyopathy that can lead to fatal arrhythmias. Its prevalence is still unknown because it's actually rare, and there is no specific gold standard test. But there are diagnostic criteria currently that has been proposed by the PODAS criteria. And cardiac MRI is actually something that is very crucial in diagnosing this patient. Plus, if you do have genetic mutation that is done, and most of these mutations could be especially desmosomal proteins. If you have mutations in these desmosomal proteins, it can point towards more to left abdominal arrhythmogenic cardiomyopathy. And some of the treatments for them is limiting sport activities, medications like beta blockers. Some studies have shown ablation of scar tissue that's helped to improve mortality. But out of everything, ICD has been one that has really shown to improve mortality in this patient. And that's why we had our patient on ICD before he left the hospital. And here are my references. Thank you.
That was an excellent case. My first question was going to be, did you rule out other cardiomyopathies that can cause sudden cardiac death? Like cardiac sarcoidosis. Between PET and cardiac MRI, they're both useful. So the images that you showed, the pattern was not consistent with cardiac sarcoidosis.
Yeah.
And there's very limited data on like LDEC, right? So we know how to take care of the right side. But in terms of diagnostic criteria between, should we utilize EKG? Should we utilize a cardiac MRI?
Yeah.
So it would have been nice to have the genetic testing for this patient.
Yeah.
But very interesting case.
That's a very good comment and a question at the same time, because that's one of the things the PODAS criteria wanted to really emphasize. If you have that pattern on the cardiac MRI and you had a plus or minus, but mostly they wanted to stress the genetic mutation that points more towards the left dominant arrhythmogenic cardiomyopathy. Yeah. But there's the study from Felix that did mention that if you had that pattern, you most likely had a 92% chance of having the left dominant arrhythmogenic cardiomyopathy.
Okay.
Any role for cardiac muscle biopsy, especially when we try to rule out other causes, but other causes can present atypically as well. I don't know if you know data on that.
Yeah, that's actually a very good question. With the technological advancement, we are trying to move away from that. And that's back in the day, they used to use that to differentiate between, in several cases with non-ischemic cardiomyopathy, with sarcoidosis, and comparing that with, like, for example, isolated cardiac sarcoidosis was something we're thinking about, or with arrhythmogenic cardiomyopathy. In 1994, the International Task Force actually used to encourage that, but in 2010, the modified criteria changed it. They actually noticed that patients, because of the study, the trials they did, noticed that cardiac MRI was actually very diagnostic, so they did not encourage EMB, like biopsy. They didn't want that. Yeah.
Yeah, and then sometimes, obtaining that cardiac biopsy, while useful and gold standard, the patchy nature, for example, cardiac sarcoidosis, you may miss it. So,
Yeah.
There's been a trend to go
Absolutely.
towards the non-invasive techniques.
Yeah. Thank
Any
you.
questions from the audience? Okay.
Thank you.
Thank you.
Okay. Yeah, so next we'll have Dr. Trishala Kesaredi for her presentation on Stop Goes My Heart, Permanent Pacemaker Implantation for BRASH Syndrome-Related Complete Heart Block.
Thank you. Good morning, everyone. This is Trishala. I am a PGY2 resident from St. Vincent's Hospital, Worcester. I want to present an interesting case of BRASH syndrome where we placed a permanent pacemaker. So, as introduction, what is BRASH? It is a component of interrelated clinical entities. They are bradycardia, renal failure, atrioventricular nodal blockade, shock, and hyperkalemia. It's relatively new and hence most of the times tends to be underdiagnosed and hence undertreated. Our case is a 69-year-old male patient who presented with chief complaints of lightheadedness, poor appetite, and decreased urine output. He mentioned that 4 days before presentation, had a big protein meal following that, had very poor oral intake, both like regular diet and fluids, also had urine output decreased to more than 50% of his normal, and started having generalized weakness, dizziness, and a pre-syncope on the day of presentation, and came to our ER. Digging into his past medical history, it's significant for hypertension, type 2 diabetes, dyslipidemia, stage 3 CKD, and morbid obesity. No known coronary artery disease. In the emergency department, his vitals were significant for heart rate as low as 27 beats per minute, blood pressures low to 80/20. EKG showed a complete heart block with an escape rhythm but normal QT interval and T waves. Meanwhile, his labs came up showing creatinine of 6.6 and potassium high to 6.5. His baseline creatinine is around 1.5 to 1.8. This is his EKG in complete heart block, and the heart rate was around 33 and with a ventricular escape rhythm. Further digging into his home medication list, he was on atenolol, and with his heart rates and blood pressures, we held at it, started fluid resuscitation, admitted to the ICU, and started on the dopamine drip. With medical management, his potassium was lowered to 5, but he remained in complete heart block, and the heart rate was still in the 30s. Moving on to his course of events, initially both the cardiology and the ICU teams were giving time, 1, for atenolol to clear off, and 2, to improve the perfusion to the kidney, improve the AKI, and that also along with the medical management of hyperkalemia. But his renal function continued to worsen. Then decision was made to start him on dialysis. In the next 48 hours, his potassium was normalized. It was down to 4. But whenever we come down on the pressor support, he was again bradycardic to as low as 20s, and the rhythm was again complete heart block. Meanwhile, we did a transthoracic echocardiogram, which showed a normal EF. And though all the metabolic derangements were corrected, and we did give enough time for the drug to clear, there was no improvement in heart rate. Then the decision was made to place a permanent pacemaker. This is the EKG, which shows a ventricular paced rhythm. So what is BRASH syndrome causing all this? I would say it's one of the detrimental feedback cycles. In patients with chronic kidney disease on AV nodal blocking agents, usually an inciting event like dehydration or an infection or anything causing hypovolemia, which triggers acute kidney injury, that in turn causes hyperkalemia and also decreased clearance of the AV nodal blocking agent. So both hyperkalemia and decreased clearance cause a synergistic effect and cause bradycardia. This in turn decreases the cardiac output, hypotension, and worsening AKI. So it develops into a vicious cycle. If the events occur alone in isolated patients, for example, hyperkalemia in patient A and just decreased clearance in patient B, in patients with BRASH, the effect is much more because of the combined effect. Also, in these patients, we always don't see potassium levels as high to 6 or 6.5 to cause rhythm changes like bradycardia or sinus arrest. In BRASH syndrome, because it's a synergistic effect, potassium can be like high normal as 5.2 or 5.3 as well. And most important point in management, because this is like a very fast vicious cycle, all the time, though we don't see hyperkalemic changes on the EKG, better we give the patient calcium gluconate to stabilize the membrane of the cardiac cells. And we do have agents like atropine in the ACLS algorithm, but well, they work good for vagally mediated bradycardia. Here the cause is totally different, and they do not correct the actual cause of bradycardia. Despite most of the AV nodal blocking agents are dialysable, there's no perfect literature telling the level of clearance with each session of dialysis. Hence, despite improvements in metabolic derangements, the initial vasopressor support or like the transvenous spacing we give helps us tide over the initial hemodynamic instability phase, but don't correct the cause. In our patient, improvement was noted only after implementation of permanent pacing. We did follow up after 12 days, and he continued to be 100% paced, and all his vitals were stable. BRASH syndrome feeds into this feedback cycle very quick, and there are multiple complications, and failure to recognize can have like very devastating consequences. One, of course, worsening renal failure, which requires dialysis. Two, a lot of patients from bradycardia and hypotension landing in multi-organ failure, shock, and cardiac arrest. There are case reports actually which spoke about patients who arrested from BRASH syndrome. With this case, I would like to highlight the importance of this devastating consequences. Also, physicians should have a very high index of suspicion. In patients who have resistant bradycardia or self-potentiating bradycardia, even with mild hyperkalemia, mild AKI, but are on AV nodal blocking agents. If we pick this early and start fluid resuscitation pressors and pacing, we can save their lives. These are the references. Thank you. Sorry.
Great presentation. You know, I'm taking care of a BRASH syndrome. It's always in hindsight when you realize what you actually treated. But what's interesting about this was the EKG that you initially pulled up. These patients, you know, like you think with a beta blocker toxicity, you may or may not have elevated, you know, like potassium. But it's almost always, you know, it's required for the diagnosis with BRASH. But more interestingly, when you look at that initial EKG for the potassium level that you have, you typically see EKG changes, but with BRASH syndrome, you have that consistent bradycardia pattern without the peak T waves and the usual hyperkalemia changes. So that's always interesting. But good case presentation.
Thank you.
I just have a question for once the pacemaker was in, do you know what were the low settings for the heart rate? Because the patient was 100% paced. Do you know what was the setting?
Yeah, it was set at 66 beats per minute.
Okay. So, yeah, that's something that,
was the issue.
as I say, 100% paced, we try to kind of decrease the setting as much as we can, as 100% pacing is something that can lead to cardiomyopathy. But, yeah, maybe a little bit on the high side because of all the other symptoms, I guess. Any other questions? Okay, thank you.
Thank you.
So that will be all,
Yeah.
I think.
I guess that concludes the sessions. Thank you, everyone.